Hey, my name is Aaron Himmler. I'm the Associate Athletic Director for Sports Medicine and the Head Football Athletic Trainer at the University of Cincinnati. It's an honor to take part of the 10th Annual Southwest Conference Athletic Trainers Summer Seminar. I really admire the work that you and your group does and puts on and all the effort that you put towards continuing education for athletic trainers in your area. So today we're going to talk about risk mitigation and prevention of sudden death in athletes. I have no disclosures for this talk. However, I think it would be pretty sharp if I did, but at this point in time, no disclosures that I have to discuss. I've given this talk or a talk similar to this twice before this summer, and it's a talk and a topic that is near and dear to my heart because in the summer of 2020, my boss's grandson, Matthew Mangine Jr., passed away due to a sudden exertion-related event at one of his soccer practices. Myself, our staff at the University of Cincinnati, we had front row seats, basically to this event, this catastrophic event, and we unfortunately, we're witness to, how a situation like this tears apart a family, a school, a community, and, how difficult, the event like that can be when someone does suddenly pass away. So if you're an athletic trainer that covers a high school, a college setting, a physical therapist or PTA, a different clinician maybe that supports an athletic trainer or helps provide coverage at a school or an athletic event, know this, that you all are stakeholders. There's a chance that you may become the person that is responsible or the most qualified individual in the time, where someone needs their life to be preserved. And that's a heavy burden, to bear sometimes. But as you're paying attention to this talk, as you're out at your schools, at your events, providing coverage, also know this. Know that what you do in these situations matter. The training, the education that you go through, the discussion of events and things like that. Knowing what to do in these situations and how you handle them. And what you ultimately do in these situations matter. And also know that what you do not do in these situations will matter even more. It will matter to, again, someone's parents, a community, a school, and you not being prepared, you not having the resources necessary may put you in a situation where what you don't do or how you do not act accordingly will matter very much to somebody. So our objectives for today are to review and understand and be able to implement the current standard of care in the management of non-traumatic catastrophic injuries. Review and understand policies that may be governed by your local jurisdictions, your state, practice acts, your national laws, various guidelines or recommendations that should be followed to basically mitigate risk to your patients that you provide care for, and also secondarily to that, help provide a buffer, a shield for you in a situation where litigation may become a thing. And then also to review and understand strategies for emergency preparedness and having your tools and your different things available and ready to be used at a moment's notice. It is estimated that over 7 million students participate in high school athletics and over 500,000 students participate in college athletics annually. So with such large exposure, there continues to be a considerable amount of non-traumatic catastrophic injuries and death every year, most of which are widely deemed preventable by various medical communities. Thus why I think this topic is so important, to us, to our patients, that a lot of what we see and ultimately a lot of what we hope to prevent actually seems to be preventable in one way or another. The National Center for Catastrophic Sport Injury Research is based out of Chapel Hill, North Carolina. It's really the group, at the collegiate level that tries to gather and synthesize all of the data that is out there about catastrophic injuries that happen in any given year. Some of the more recent information is this, and in the last two academic years, the 2019 2020 and then 2020 2021 school years, there were 46 high school athlete deaths. 37 of those 46 were sports related, so 80% of all of those deaths had some relation to a sporting event. The majority of sport-related catastrophic events were, that year at the high school level, and most of those deaths that did occur happened in males. That National Center for Catastrophic Sports Injury Research, basically breaks their events that they track down into two different categories: the direct and indirect events. Direct is kind of more specifically defined as traumatic injuries. Those are in 21.9% of those traumatic injuries or direct events, they were fatal. 6.3% were non-fatal but permanently disabling. 43.8% were serious with recovery, and the unknown outcome in 28.1%. In those exertional or medical indirect events, 35% of those were fatal, 2.9% resulted in permanent disability, and 61.8% of those recovered. The biggest majority out of those types of events, 88.2% were cardiac related, and then 5.9 were heat related. Those were basically the two biggest contributors to that category. Thus why I'm going to spend the biggest portion of this talk kind of looking at those two specific avenues of exertional events. Every year you see when we are doing our annual training with our staff, our sports medicine fellows, the various residents that provide coverage to our local high schools, one of the first things that we talk about is sudden collapse. And when sudden collapse occurs, the thing that we're teaching our colleagues is things that should immediately be going through your mind when this situation presents itself. So when someone does collapse on a field or on a court or wherever it may be, we think about the three H's: heart, heat, and head. Those are the kind of in order the three things that your wheels need to start turning about. And then we also throw blood in there for exertional sickling. Research has shown that 90% of all sudden death in sports is caused by one of these four conditions. So when we think H, the first H, heart, is sudden cardiac arrest. The second H is heat, exertional heat stroke, and third is head for some kind of traumatic head injury. So these are things we'll discuss. Sudden collapse etiology. Sudden collapse is estimated in 30 to 40% of the population. Quite honestly, those numbers are very likely underestimated. For probably a lot of the situations where you have some kind of syncopal episode, a lot of that just flat out isn't going to get reported. So that number really, quite honestly, could be significantly higher than that 30 or 40%. Cardiac syncope is caused by a temporary global failure of cerebral brain perfusion because the heart does not have enough output to basically get that oxygenated blood to the brain. The two reasons for those are either mechanical or structural, or electrical. So, to put a little bit of light on it, it's either the mechanical engineer's problem, structural, the plumber's problem, or the electrical, conductivity of the heart has failed or has gone amiss, and that's the electrician's problem. So within mechanical or structural, etiologies of sudden collapse, that's broken down into three different categories. You have your ischemic cardiomyopathies, your valvular abnormalities, and 3, your non-ischemic or dilated cardiomyopathies. So with all 3 of those, there's something that is structural about the heart, something mechanical that is not working the way that it's supposed to. And then when you look into the electrical category, you have your number 1, you have your tachycardia, your heart's just beating too fast. Number 2, bradycardia, in some way, shape, or form, your heart is not beating fast enough or is beating very slow. And then 3, your channelopathies, which is your long QT syndrome, your Brugada syndrome, different things where the electrical conductivity is not following the pathway that it should. When we think of types of sudden collapse, there's 6 kind of silos or categories, if you will. The first is simple fainting or vasovagal episodes. This can occur when you're sick, you got an illness that you're dealing with. Sometimes we see it in your fight or flight situations where someone sees blood, they hear bad news, or something fearful occurs, and their body just basically kind of checks out of the situation. Sometimes it can be positional. Someone goes from laying down to standing very rapidly, and the blood output to the brain just can't make it there quite as fast as it needs to, and you lose oxygenation for a very brief period of time, and you simply faint or pass out from it. The second category is heart-related or cardiac syncope. This often occurs during exertion. It often happens suddenly or unexpectedly, and then it can also happen when there's a family history or maybe even a genetic component of it that like some of your hypertrophic cardiomyopathies that can be familial in nature. Third, sudden collapse can be neurologic or seizures. Most of these situations, unless it's their primary presentation, you're going to be aware of some kind of previous medical history that they may have, neurologically, or they actually have been diagnosed with epilepsy. And these are kind of trademarked by, once the situation occurs and they fall to the ground, there's often some kind of violent shaking or grand mal seizure kind of presentation. The fourth category is metabolic. We see this sometimes in our diabetic patients where they become hypoglycemic, maybe hyperglycemic, kind of on the other end of that spectrum. Or we sometimes see athletes or patients that are hyponatremic. Those are things that consider from a metabolic standpoint when somebody collapses. Fifth is a pulmonary reason, basically hypoxia. You're just not getting adequate oxygenation to the brain. Whether it's a lung or both lungs at fault, it's anything along that pulmonary pathway going awry can lead to that. And then last, you have your volume depletion. And this can occur from a traumatic hemorrhage, some kind of atraumatic, blood loss that may be going on within the body, diarrhea, vomiting, or just heavy sweating and just kind of frank dehydration. Those are all things that can lead to an overall depletion of volume and lend itself to someone having some kind of sudden collapse. Recognition as it relates to a cardiac related sudden collapse is really one the primary thing for those that have had an athlete collapse in front of them. You kind of get shocked by the situation at first because it's something that happens just kind of spontaneously and not something that you're necessarily sitting there waiting for for it to occur. So any athlete that collapses in front of you and becomes unresponsive, the sudden cardiac arrest should be kind of at the forefront of your mind and should be suspected anything that is non-traumatic. I can't remember exactly who the physician was, but I remember at the College Athletic Trainers Society meeting out in Las Vegas, I believe it was a team doc it might have been the Naval Academy, and he made some kind of quote about in 70% of sudden collapses that you tend to, 70% of them will be cardiac related in nature. I don't know if that's an exact number, because I can't remember where the quote came from, but nevertheless, it's a number that has always kind of stuck in my brain. That when one of these situations occur, the very first thing you need to think of is heart. Again, going back to that paradigm of the 3 H's, heart is where your brain should immediately kind of be flipping towards. When a cardiac related sudden collapse occurs, brief seizure-like activity is common, until proven otherwise, that or if you have that firsthand knowledge of this person having epilepsy, thinking seizure first is not necessarily the way to go. Continuing to think that this is heart related is going to be the best way to go about this. Occasional gasping or agonal breathing is something that presents in this type of situation, and know that it is not normal breathing. It's your body's attempt to try to get kind of its last couple of big breaths and to help sustain oxygen within the brain. But again, in these situations, think sudden cardiac arrest. Resuscitation pathophysiology. About 40% of out-of-hospital cardiac arrest victims demonstrate ventricular fibrillation. And again, should be reviewed for everybody, but ventricular fibrillation is one of those, 2 different types of rhythms that are shockable and, will be analyzed by an AED. And that's, characterized, ventricular fibrillation is basically characterized where the bottom of your heart, those ventricles are kind of quivering like a bowl of jello, instead of, getting a good, solid, rhythmic contraction of pumping, the blood out to the various parts of the body. And as you can see by the little, illustration video to the right, the electrical pathway just basically gets stuck in the bottom of the heart, and it just kind of at random, fires and isn't doing its overall job that it's supposed to. The probability of successful defibrillation for ventricular fibrillation diminishes rapidly over time, and we know that survival rate decreases or declines by 7 to 10% every minute that defibrillation and good CPR is delayed. And once ventricular fibrillation deteriorates to asystole, survival is unlikely, because again our AEDs aren't designed to restart the heart. It's simply just to shock it back into a normal rhythm. The American Heart Association has a chain of survival, four steps or 4 links to emphasize time-sensitive interventions for victims of sudden cardiac arrest. Those are as follows. Number 1, first and foremost, is early activation and recognition of the situation, calling 911 and basically getting EMS en route to your location. Number 2 is early bystander CPR. Continuing to get the blood flow that is within the body pumping around as fast as you can. Number 3 is early delivery and shock with a defibrillator. And number 4 is those 3 steps followed by advanced life support and post-resuscitation care at a medical facility that continue that continuity of care. Heat illness is, a major thing that, especially this time of the year, that should be on the forefront of all of our minds. We're out there in these hot practices, hot conditions, humid conditions, covering and basically trying to do everything we can to make sure this is a situation that is either preventable or managed. Something I talk about with my staff all the time is not every heat illness is preventable. Heat illness is going to occur, when we're out in these conditions, but they are all manageable and they are all survivable if you are prepared. If you have the tools and the things necessary to manage that type of situation, there aren't many reasons why every single one of your patients should be able to survive this type of situation. So heat illness is classified into four different categories. You have your exercise-associated muscle cramps, heat syncope, heat exhaustion, heat stroke, in basically ascending nature of least severe to most severe. Exercise-associated muscle cramps, we all have seen them, we've dealt with them. These are these sudden, sometimes progressively painful, very much involuntary contractions of muscle, usually during or immediately following an activity or exercise. Heat cramps is kind of the popular name for them, but it's really technically an inappropriate term because these types of cramps aren't directly related to an elevated body temperature. Think that if we were to put somebody in a sauna for a really long period of time, they may not necessarily have these exercise associated muscle cramps. It's not necessarily a 1-to-1 ratio. They do not readily occur after passive heating at rest, and they can also present even in cool temperatures. Warm, humid conditions are where it's typical, but it doesn't necessarily have to be those conditions. I remember vividly one of the rainiest games I've ever participated in was against the Miami University at Paul Brown Stadium, where the Bengals are, and it rained from the beginning of the game to the end of the game, basically kind of torrential downpour status, and we had a handful of kids cramp from that situation. And it was not a hot game. It was an evening game, quite honestly relatively cool, but still something that we saw and had to deal with. The cause of exercise-associated muscle cramps are really not fully confirmed, not fully understood. There are proposed contributing factors that could lead to it. Among those are dehydration, electrolyte imbalances, altered neuromuscular control, and fatigue. I have both of those highlighted because quite honestly, I think the longer I see these, the more I do this in my own clinical practice. Those are the 2 areas that I feel may have kind of the most influence on somebody having these muscle cramps. We've fortunate enough to to do different things with IVs, pregame IVs, that type of thing. And some of our guys that are, chronic crampers, and quite honestly, we still see, those cramps occur from time to time. And I really don't believe that, dehydration and just lack of volume is the exact catalyst for these to occur. Heat syncope, or orthostatic dizziness. We see this, often in your unfit, sometimes bystanders, early into the acclimatization period, where someone, has been standing for a long period of time. The blood is kind of pooling in their legs, and they're just overall not quite acclimatized to that heat. And they may go from sitting to standing, very quickly, and everything stays, south in their legs. And with them being hot, their veins are dilated, and everything just basically stays south and doesn't make its way up to the brain. Again, this condition is attributed to dehydration, the venous pooling of blood, reduced cardiac filling, and then just low blood pressure, with that cerebral ischemia, where the blood and the oxygen just isn't making it all the way up to the top. Heat exhaustion is that next phase, and this is where things are starting to get pretty serious, in terms of that eventual paradigm of heat illness. And heat exhaustion is defined by the inability to effectively exercise in the heat, and it's secondary to a combination of these factors: cardiovascular insufficiency, hypotension, energy depletion, central fatigue. And basically what happens is your body is really just losing its ability to deal with the situation that it's in and the environment that it's in. Heat exhaustion most frequently occurs in, again, hot or humid conditions. Doesn't have to necessarily be exclusive to that. We see it all the time. The Flying Pig Marathon in late April or early May often isn't 85 plus degrees outside. At start and finish, we're somewhere in the upper 50s, maybe low 60s, and it's something that we see and deal with every year. Heat exhaustion most often affects, again, those people that are unacclimatized, or your athletes that are at that beginning phase of acclimatization, and the body hasn't fully adapted, or individuals with a body mass index of 27 or higher. Me working Division I football, our big guys up front, or D linemen, O linemen, are the ones that I'm constantly worried about, as they seem to not necessarily deal with heat as well as some of the other position groups. And then obviously we have heat stroke. This is the most severe form of exertional heat illness. There are two and really only two signs and symptoms that you have to confirm heat stroke, and that is hyperthermia with a core body temp of 104.9 or higher, and then secondly, some kind of central nervous system dysfunction. The first thing we think about there is some kind of altered mental state. You may have the patient that becomes aggressive or irritable, or may have just complete and total confusion, and all of a sudden almost act as if they don't know where they're at. They don't know their surroundings. They're unsure of kind of what's going on. So those things those two things are the classic signs and symptoms that if you see those, heat stroke needs to be right at the tip of your tongue and at the forefront of your mind, and in terms of what your differential diagnosis should be. When we do have a heat stroke situation, the patient should be cooled within 30 minutes of presentation. And what we follow at UC is we're going to keep them in that cold tub until we get their core body temp down to 102 degrees. And I'll go into a little bit further detail here shortly about how approximately how long that takes and the science behind it. So heat stroke is really a product of both metabolic heat production, so basically kind of your internal own heat that your body is producing by working hard, using your muscles, running, breathing heavy, that type of thing, coupled with that environmental heat load that you're getting from the ambient area surrounding you. And with those two things combined, you're basically getting cooked from the outside and you're getting cooked from the inside, and your thermoregulatory system eventually gets overwhelmed, and it loses its ability to deal with that particular situation. Heat stroke is a medical emergency, and you have after those 30 minutes of presentation, or 30 minutes of that core body temp getting basically into that 105 degree temperature range or higher, you're starting to risk an increase in organ damage, morbidity, and mortality. And the average EMS response time to transport to ED care, that window exceeds 30 minutes, and that's a big reason why we have the cool first, transport second kind of mantra that we follow as in athletic training. Athletes that are more susceptible to exertional heat stroke are athletes with sickle cell trait, anybody that has a current illness that they're either battling or have recently battled, someone that currently has a fever. If you're already starting at 102.5, it doesn't take that much effort for you to get just a couple degrees higher and get into that 105 plus range. Someone that has inadequate rehydration, we, especially during camp, we're constantly looking at that 3% body weight loss or greater, on a day-to-day basis from that way in to way out. Other people we are concerned about are those who are kind of the warriors on the team, and they just flat out are going to push themselves to workload capacity. The guys that just are going to go basically until they collapse. Make sure who those individuals are and identify them. And then another thing we discuss often is this heat intolerant state versus trait. There's a concern that once you have a heat illness, the subsequent ones that you may deal with afterwards, your body loses its ability a little bit to kind of bounce back as fast as it did from that, or deal with those situations moving forward. And then from a trait standpoint, there may be some of us just genetics wise that don't deal with heat illness as well, and kind of that metabolic overload of internal heat coupled with your environmental heat load. Some of us just may not handle it very well, and we need to understand who those individuals are and identify them in our clinical practice. And then another big thing that we at UC have been really kind of paying attention to is our athletes that are taking some kind of stimulant or have been provided or prescribed some kind of stimulant, whether that's an ADD medication or other medication that can basically increase your heart rate and kind of your overall metabolism. ADHD medication has a known link to hyperthermia, and that's something that we feel that we need to know specifically with each of our athletes, and identify who those athletes are. That way we can basically pay more attention to them, or closer attention to them in those hot and humid conditions. That way we can spring into action a little bit faster. The Corey Stringer Institute at UConn and Doug Casa are really kind of the people on the forefront of heat illness in our profession. Both are great great resources to follow on social media and stuff like that, because they're always putting out some really good stuff. And something I just picked up, I believe on Instagram a couple weeks ago, was the Corey Stringer Institute was talking about how The human body can tolerate a core body temp of 105 degrees or higher for about 30 minutes. Once you get into that 30 to 60 minute range, it is very likely that you'll have long-term complications and possibly death, because in those situations cardiac tissue is getting damaged. You could potentially go into cardiac arrest. Brain tissues are getting damaged. Brain cells are basically getting burned up, and those will never come back. Can lead to cognitive dysfunction. Your kidney, your liver, or kidneys, your liver can be damaged by this. And then you can also have something called rhabdomyolysis, where you're getting just that muscle breakdown, and that can be toxic to your system. So again, getting those patients cooled as fast as possible is absolutely paramount. So how do we treat that? Full body ice immersion is really the gold standard of getting that elevated body temperature down as fast as possible. And you're looking to have a water temp of somewhere between 35 and 59 degrees Fahrenheit. And then when you get them into the tub, you're trying to vigorously circulate the water. And again, that primary goal is getting them down to 102 degrees within 30 minutes. If you have an athlete that you're suspecting of heat stroke, activate EMS, get them on the way, get them there. That way, you're not waiting around for, maybe a really long response time, or, another situation that you basically don't have full control over. So getting them on the horn and getting them headed in your direction is key. Again, cool first, transport second is our mantra within athletic training, and it's there for a reason. Most hospitals, most trauma centers, quite honestly, just are not prepared to deal with a heat stroke. They don't have a cold tub set up at all times to utilize in this situation. So if they don't have it, and you haven't cooled them by time EMS arrives, they get transported, they get to the hospital, and it's recognized that they have heat stroke, a lot of time has likely elapsed. And we as athletic trainers, and again, as long as we're prepared for it, are really the perfect ones to deal with this situation. Continuous rectal temperature measurement is the gold standard of knowing what that elevated core body temp is, and how low you're getting with your interventions that you're deploying. And then also IV fluids and supplemental oxygen, if you have the ability to do those things, are also paramount to have it, at your utilization, at your fingertips, to help provide a better level of care for your patients. So looking specifically at cold water immersion, the three fastest methods are ice water immersion, defined by 35.6 degrees Fahrenheit, cold water immersion, and then ice water immersion with just your half of your body. So if you see on the right side of that graph, I have those three things highlighted in red, and then I've circled that cooling rate of 0.2, and that'll make sense here in just a second with this next slide. So with a cooling rate of 0.2 degrees Celsius per minute, you have kind of this red triangle area of basically your core temperature during cooling, and then across the bottom you see the time in minutes, and those three fastest methods fall within that 0.2 rate or higher. And those things, if you have those temperatures of water, you're able to get that body temperature down to 102 from 105 plus 106, 107, 108. So you're getting them to decrease approximately 5 degrees within 15 minutes. and those are the three methods that really are the standard of getting those things down. Prevention and preparedness, this is really where your ability to do your job comes from, is your knowledge of, working knowledge of situations and how prepared you are to deal with them when they occur. In 2018, Jordan Mcnair, who was an offensive lineman at the University of Maryland, passed away, and it was, the cause of death ended up being ruled as heat stroke. And I remember, pretty vividly this time, and we had a lot of conversation with amongst our staff, and I remember telling our staff like that, this one feels different. This one, is occurring at a Big Ten school, a school that has a lot of money, a lot of resource, and it's this news story is all over ESPN, and for whatever reason, it felt like this was going to be an unfortunate story, that really led to some drastic change, I think, in college athletics. So it was ultimately something that we naturally kind of paid a lot of attention to as it played out, and more details of the situation emerged. In light of the situation, two of the athletic trainers were fired at the University of Maryland, and became a really big deal for that university, and there was concern that they may lose their accreditation. In just this isn't what should be going through your mind as you're planning for these situations, preparing for them to occur and acting the way that you're supposed to, but realize that there is a real world backlash that comes from it if they are not handled appropriately. And I think that's having quite honestly, that fear is not necessarily a bad thing, because it for me at least, it acts as a self-reminder. It acts as a challenger to make sure that when I'm on the field, covering a conditioning session, that my mind is where it needs to be, other than obviously the reason why we're out there is providing a high level of care for our patients. It is a real world reminder that there are other ramifications that come from a situation being not handled appropriately. The Rod Walters report, he was a longtime athletic trainer that ended up being kind of the independent consultant that the family hired to kind of go back and look at and evaluate the procedures and protocols that were related to Jordan Mcnair's death, and how Maryland handled them or didn't handle them. And it's a document that I would recommend any athletic trainer to read, because we read it when we got a hold of it and it came out, and bluntly, it kind of really truly changed the way that we prepare ourselves for conditioning sessions, for practices. And it's a pretty blunt and pretty heady document in terms of what it spells out that did and did not happen, but I think it's a document that, again, every athletic trainer should read. About a year, almost to the day after Jordan Mcnair passed away, this document came out for us at the NCAA level, and it was quite honestly a document that should have come out a lot sooner than what it did, but it is a document that really has changed a lot of our day-to-day care for our athletes as it relates to us trying to prevent these catastrophic injuries and deaths in our athletes. Within this document, it basically spells out that at our level we should be doing an annual education training session with our basically our key stakeholders, most importantly, our allied healthcare professionals, our athletic trainers, our team physicians, and then secondarily our strength and conditioning staffs, because between those two staffs, those are the ones that are really going to be dealing with the bulk of these situations. So within that annual education training session, we're tasked with going over our EAP, emergency action plans, head and neck injuries, cardiac events, environmental monitoring, how we do it, why we do it, what our resources are there, exertional heat stroke, heat illness, sickle cell trait, associated collapse, asthma, rhabdo, diabetic emergency. So it's a pretty exhaustive list of things that we need to go over and educate our staffs, and if nothing else, it's a great reminder, a great refresher of the things that we need to be thinking about. And this is something that for those of you that are a high school setting, I encourage you to employ as well with not only yourself but also a strength coach or strength coaches that you may have, or maybe even your head coaches, to make sure that everybody is really kind of on the same page. This document really was endorsed by a large handful of major important associations and groups, and really for us is now very much a standard of care. So standard of care is kind of a hot button topic, and in my mind it's a little bit of a moving target, because things are constantly evolving, constantly changing. There's new information coming out, and I think this is an area where us as athletic trainers, we got to have really kind of an active kind of ongoing continuing education role in understanding what the standard of care is. When I say standard of care, I'm going to kind of illustrate here with what we got, but there's a ton of position statements and official statements and consensus statements and different handbooks that we at the NCAA level have to look at and follow, and then throw mental health in there. There's a bunch of different best practices that have come out of that, and really just the as you can see, the documents that we have to be aware of and pay attention to, and things that can be held against us are pretty vast. And I encourage each of you and kind of challenge each of you to make sure that you're staying kind of on the forefront of all of these things. So when we talk about standard of care, things that I think we and you, especially at high schools, need to be kind of very tuned into are your State Practice Act, your licensure laws. For us here in Ohio, our State Practice Act has just recently changed and really has opened up and broadened, and now gives us kind of the latitude to do some of those advanced techniques like IV access and supplemental oxygen use and those types of things. So if you're in one of those states where things are starting to expand within your Practice Act, knowing what your limitations are, I think is very imperative. Other things that you need to know are any standard operating procedures that your employer has. Your State Practice Act can say one, but if your employer won't let you do it, or that type of thing, or has a certain procedure that you need to follow to employ one of those things, it's imperative that what that looks like and how it spells it out. Your state high school athletic association, any recommendations they have. Again, I've talked a little bit about the NCAA prevention of catastrophic injuries document that we have to follow, but knowing if the state of Illinois has and their athletic association has a group of recommendations that you need to follow, knowing those kind of inside and out is definitely imperative. Arguably, EAP is one of the most important, if not most important, things that you can have. It's a document that you need to look at, on an annual basis. And if your EAP says it, you better do it. Because if you find yourself in a situation where your EAP says one thing and you didn't act accordingly, you basically have that hard, black and white document that says you should have responded this way and you didn't. So making sure that you know it and understand it and how to implement it is very important. Again, standards of care, as in my opinion, is a little bit of a moving target. You need to know those formal standards of care, the consensus statements, the best practices, of how we as a medical community have basically decided that these different situations need to be taken care of. And then you have your informal stuff, kind of like the Rod Walters Maryland report. It's not something that is has been backed by the AMSSM, NATA, CATS, that type of thing. But if you get into a situation that's litigious, other cases like Maryland are going to be pulled up and used against you. So keeping kind of your ear to the ground, if you will, about other cases that occur across the country, I think are things to be very aware of. And then finally, you need to know the names of CASA, Dresner, Ron Corson, Rod Walters, and the various documents and publications and articles that they put out, because those are some of the names that are very highly regarded, in emergency management, with our patients, with our athletes. And if you have if you unfortunately find yourself in that type of situation, and you have a savvy, family, they're gonna use this group of people as expert witnesses. So knowing, them, knowing what their publications are, I think is very important, because I can tell you I wouldn't want any of them on the other side of the courtroom as me. They're the best at what they do, and a lot of people know their name for a reason. Again, emergency action plans are the cornerstone of your ability to be prepared, your ability to be ready for catastrophic injuries should they arise. This is something that should be posted. It should be available to everybody. It shouldn't be a secret. It shouldn't be guarded in a binder hidden somewhere in the top shelf of your cabinet, your athletic training room. It should be centrally located, very easy to find. At minimum, you need to be rehearsing them, going through them, thinking about them, at least once a year, if not more frequently. The equipment necessary should be available at each venue. I'll go over that here in just a minute, but I think that's another area that's really important, is having all of your tools in one spot, should they need to be used. One thing that we do at UC with all of our home and away games is we basically do a pre-event medical timeout. We'll gather everybody at basically midfield and kind of go over who we have, who our staff members are, what kind of physicians we have available, what kind of resources we have available, and then go over kind of our EAP and what our cross streets are, what our landmarks, that we need to think about when we're, if we're calling or activating EMS, and they're not, there on the sideline with us. We have blue help phones on campus. Those are things to be aware of if you have something like that to use as a, basically a backup or a secondary means of activating EMS. Knowing your capabilities of the responding EMS services, I think is paramount. Knowing if you have a full-time fire department versus a volunteer fire department, having a ambulance service that is ALS versus BLS. I think those are all things that you need to know ahead of time, and not trying to figure out in the heat of the moment. Our hospital something has air care, which is helicopter-based air transport system. When we go out to higher ground out in Indiana for training camp for football, having a conversation with that local fire department about if this situation occurs and air care needs to be summoned, how are we going to do that? Who's responsible for that? Where are they going to land? Who's responsible for getting the landing site set up and those types of things. So if you're at a high school and you're at a rural high school that maybe a helicopter is going to be one of your better means of transportation if there is a truly catastrophic injury that needs to be managed time critically. You need to know which facilities are around you and how long it takes to get there, whether they're a level 1 trauma unit, whether they're a lower level facility that may be restricted in what they can do in their interventions. Identify the location of your emergency equipment. That it all needs to be together. It needs to be in one singular location, and you're not trying to scramble to find places or find the different places where these tools and things may be hidden. Any challenges in communication? We have some uniquenesses at UC with our radio systems that we all need to be aware of, and the different channels that work inside the building versus outside the building, that type of thing. Again, and most importantly, is just reviewing and rehearsing these things and any associated documents that you may have. I listened to Rod Walters present in 2019 over failures of EAP, basically, and when he's consulted with to retrospectively review policies and procedures that have gone awry. These are the things that he presented to us, and that his kind of list of errors that he most commonly sees, and those are no posted venue specific EAP, a failure of coverage model, and just a lack of planning, a lack of training, failure to identify escalating symptoms of exertional heat illness, failure to assess core body temperature with rectal thermometry, and failure of EAP relative to appropriate equipment, not having a weather monitoring system of some sorts, not having a cold tub there and readily available. Those are the things that he sees the most commonly when he's summons to be a consultant. So with those things and things that we need to have at our fingertips, are things that we'll talk about here in just a second. Having one of these catchwell units, we got a handful of these recently. You see, and they're phenomenal. If you don't have one, I couldn't speak more highly of them. They can link up to your smartphone. It can gives you a great readout of all the different measurements and metrics that they take, and knowing what that wet bulb globe temp is really the gold standard, and how that measurement can impact the human body and its ability to cope with the environmental conditions. Full body ice immersion, having a cold tub set up and ready to go as you go into a conditioning session, or as you go into one of those outdoor events that's in the hot and humid situations. Don't wait to try to fill up one of these 300-gallon horse troughs, basically, as the exertional heat illness situation is occurring. Be prepared, have it set up ready ahead of time. That way, if it happens, you're not losing that valuable time to quite bluntly save someone's life. Rectal thermometer. I know at the high school setting that can be a little bit of a touchy subject, but it is well known that it's the gold standard. We have them in our trauma bags at UC, and it's something that we all discuss and rehearse in our heads, that if the time arises, it's something that we're going to do, and it's something I feel strongly about, because the most recent time I gave this presentation, for the questions at the end, there was a high school athletic trainer, and basically said, like, what do you recommend that I do at the high school setting? And we've had this conversation, and the administration isn't quite on board with it and that type of thing. And I think this is where it comes down to educating. I think you need to educate your stakeholders at your setting, your high school, your coaches, your administrators, and try to put something in writing, send an email saying, hey, this is the gold standard. Here's why I think these things need to occur. I think this is why we need to have this device. Why I need to be ready to use it, and basically need the support of everybody to use it, because if you don't have the ability to assess that core body temp, and that core body temp is significantly higher than you think it is, you're missing out on an opportunity to save a life and in a situation that is can be very controllable. AEDs. Know where your AEDs are at. When you go on the road and you're traveling with them, it should be one of the first things you're looking at. Become pathologic about it. Get off the bus and be like, all right, where's the AED at? Where can I find it if there are other ones that you may be in the surrounding area. And kind of as Jerry Maguire says, location. Know where they're at. They have to be accessible. They have to be ready to be used. It can't be behind a locked door. It can't be in some storage closet where nobody knows where it's at. Time is of the essence when a sudden cardiac arrest occurs, and it needs to be something that is very close by and ready to be deployed. Trauma bags. This is something that came directly out of the Rod Walters Maryland report, and something that we implemented at UC that I would encourage each of you to really strongly look into. And the idea here is, again, when one of these emergent catastrophic injury situations occur, time is of the essence. You can't be rifling through drawers finding all of the different tools that you need. So we bought these trauma bags, one for basically each location that we have, each venue. That way you have a all-encompassing bag that has all of your utilities right there. This bag includes a stethoscope, blood pressure cuff, a pulse ox, glucometer, a Datatherm rectal temperature. It has an IV, intravenous kit in it with a little module that has everything you would need to start an IV. It has an airway module in it where we keep our eye gels, our oronasopharyngeal airways, SAM splints. Then we've got like a universal module in it that has all of our first aid stuff, whether it's ACE wraps, band-aids, hemorrhage control things. And then we also keep 2 cervical collars, a bag valve mask, an extra AED prep kit, a heat illness flash card or emergency card that I'll show you on the next slide, along with our athlete emergency info card. And then at each of our venues, our locations, we make sure that we have an AED, an oxygen tank. And then we also just recently, at the recommendation of our EMS service within the hospital, we just purchased some battery-powered suction devices, and the goal is with your trauma bag, your AED, your oxygen tank, and your suction device. You basically have the 4, kind of primary things necessary, all in one spot, ready to be used. And then lastly, we created these emergency cards that we keep on ourselves. We keep them in our fanny packs. We keep one in our trauma bag, and it's basically to help you in the time of an emergency to quickly recall different conditions or medications or allergies that one of your athletes may have. That way, as EMS gets there and you're trying to brief them on the situation, you've got something that you just can quickly look at and reference, instead of trying to fumble in your brain what condition this person has, or what allergy this person has, or what relevant medication that they may be on, that can be very useful for that EMS staff that's basically trying to continue that continuity of care. So I think this is a good idea for each of you to employ as well. And that's all I have for you today. We've kind of reached our time limit, but if there's any questions or concerns that you have, my email is down there at the bottom, and feel free to reach out to me, bounce ideas off of me. My email inbox is always open, and more than happy to reach out to you guys and help out with anything that I can. So again, thank you for your time. Again, I'm honored to be a part of this summer seminar, and good luck as you go into your seasons, and keep them healthy.